So for those of you who were here last year, you'll recall that we had Lloyd Paul Aiello give our summation because of the, at least from my perspective, he's one of the few people who can listen to a day like this and in minutes come up with a cogent summation of all that we've heard and make it relevant to what we do next. So, Lloyd Paul.
Well, thank you, Robert. No pressure there. I'm glad to hear I was invited back, not so I could get it right this year. But this is a challenging task because I get to give a talk with no slides, where I have to listen to every second of everything that went on the whole time, and that what I have to say is basically what some other people have said. So if you disagree with anything I'm saying, I may not be the only one at fault here. But at the highest level, I'm struck by two things, particularly since last year: growth and progress. And the growth and progress have been remarkable, and yet there's still so very much to do, which we'll get to in a bit. But just sort of look at the composition of the audience here. Such amazing diversity of interests and of all such high caliber. You look in that book, it's 57 pages of remarkable accomplishments and some really good headshots as well throughout that whole thing. But Martin started off by saying that he's looking to build supergroups. The concept is that the whole is greater than the sum of the parts, and you've heard that several times. But if these are the parts out here, then the greater sum of the parts is going to be something quite remarkable indeed. So Robert talked about how part of what we need to do here is to accelerate the development of new therapies to preserve and restore vision. And he hopes that this can be a catalyst. I think that's well underway. To see what's gone on over the last couple of years as this is involved is a remarkable testimony of how much of a catalyst he and so many of the people in this room have been. So, I really love the slide that went up about, I think it was inspired by Tom, that Robert showed, of the cell phone going to the rotary phone going to your latest device you'll have in your pockets. A couple of years ago, I probably would have been smoke signals and then, Morse code. But we're well past the rotary dial already. But this is where we can go if we put our mind to it and keep moving along in this way. Once again this year, and I think it's a wonderful thing to do, started off with a patient perspective, and Ryan shared that with us and really pointed out how personal and how frightening and encompassing these feelings can be from diabetes. And I'll say that, I'm a third generation ophthalmologist. My grandfather, my dad, myself, all in the ophthalmology field, all dedicated to diabetic eye disease. And no diabetes in the family anywhere that we know of. And we did this for years, and we thought we knew this field. And it wasn't until I was 46 years old and developed type 1 diabetes that I really knew what it meant. So it's, you really don't understand, no matter how compassionate you are about this as a physician, until you become part of it and understand what this does into your life and how it can stimulate you to do things, wonderful things, and help this important field. They then went on and saw the clinical study evolvement, Dr. Jennifer Sun presenting that, and to see how much has been done already with setting up working groups and defining the approaches and requirements to clinical trials getting started, a natural history. Very happy to see both the diabetic and the non-diabetic included in that. And then a treatment part that's going to give us remarkable new information and data, not only on how we do some of these studies, but give us some data on other visual function metrics, which is so important. And to see and understand this is going to get started now in Q2 of next year, it shows a very, very remarkable approach to how quickly this can be done, particularly when you partner with other resources that are out there. Mike Chang talked with us about the importance of the large data, and again, how the eye can be a window to the body. And this is something that my dad always thought was very important. And it points out how what we do here is likely to have ramifications far outside of diabetic retinal disease by itself. Patrice talked about the biorepository. Again, what remarkable achievement in a short period of time. Establishing, equipping, training the people, multiple SOPs already in place, 7 iBank centers brought in over 21 states. This is tremendous, and the lovely summary by Mark Atkinson pointing out how important this type of repository of human tissues is going to be as we take these repositories and put them more towards disease complications. That's going to be phenomenal. But perhaps the part I liked the most was the concept of avoid the museum. This was, I thought, really wonderful, and to see with Mark's help and the University of Michigan and so forth, they're on that end of it, trying to do everything they can to make sure it's not a museum. But at the same time, it's up to all of us to make sure that we utilize these resources, we put them towards good use, and we make the discoveries that are needed to move forward. Then we had our regulatory session. Again, always a lively discussion as always. Lots of good thought and questions about how we might be eventually able to develop new areas to look at and how this will be utilized and how it might be utilized. And Dr. Chambers, again, very well defining the aspects that are now accepted and the type of things we need to think about if we're going to find other endpoints and so forth that can be utilized in this way. So now it's really our job to think about this, evaluate these other things in the same way that the initial clinical trials are getting started to, but in so many other ways as well, so we can start to eventually try to make a reality endpoints on visual function more than what we have today. Hot topics were fascinating. Diabetes and diabetic retinopathy is not just pertinent to the adult population, but to so many more, and particularly with type 2. Type 2 in children, when I started my career, hardly recognized at all, and so that's been tremendous. The efforts on the PROs and what's needed there and what so much has been done and the other aspects that's going to become more and more important as we do these clinical trials and involve it. And then telemedicine, and particularly AI. There's no doubt that the AI over time has a lot of growth to do, a lot of areas you have to be very careful about, but the AI is going to radically change how we do many of these screening programs and assessments, particularly as you start thinking about if we're still doing fundus photographs and have to handle 1.3 billion images a year. And finally, this last session, how inspiring and enlightening was that? Particularly for me, that was incredible to see the efforts that the entertainment space is dedicating to this vision and this effort of so many. So as we start to summarize, I would say what an amazing mind trust we have dedicated to this, what amazing accomplishment has occurred in a short period of time, and how much more we have to do, and yet we're already starting to see that exponential rise of successful organizations like this, where we're starting off, but then each year goes up, not just linearly, but probably exponentially. It reminds me of over 20 years ago when I was starting off with DRCR. DRCR started with a telephone call of 5 people in 5 different areas. I don't know if it was a rotary phone or not, but it was pretty close, okay? It was Rick Ferris from the National Eye Institute, Don Everett, who is the NEI program coordinator, Matthew Davis, University of Wisconsin, is head of the Reading Center, Roy Beck from Tampa, head of the Coordinating Center, and myself. And I sat down with a blank piece of paper on the telephone, and we talked. We didn't have a name for it yet. We had a concept of what we wanted to do, the same type of concept approach. Let's make a difference and do things no one's done before. But the only thing that came out of that first call that was defined is that any group that we were going to put into this consortium had to have access to this newfangled technology. They had to have internet access, honestly. And we did that, and we decided then that we were going to go straight to electronic CRFs, which hadn't been done very much at all prior to that point in time. And we did that, and that in the future has allowed us to do complex studies that would have been impossible otherwise. And then it took off. And I think the Mary Tyler Moore Vision Initiative is at that stage where it's starting to take off. And personally, I'm excited to see what we're going to hear about next year when we come back, whether or not I'm asked to give the summary. In concluding, I'd like to thank Tom and Jenny and all the folks at the University of Michigan for not only putting this on, but including me. And a very special thanks to Robert and to Mary Tyler Moore for their vision and inspiration and guidance on this very, very important effort an initiative, which I truly believe, like Marytown herself, who affected so many in so many ways, has the effort, has the potential over the years to affect tremendous aspects of this disease around the world, and in doing so make it a kinder and more beautiful place for all those with diabetes and all those people who love those with diabetes. So thank you very much.
Thanks, Lloyd. That was once again very special and very appreciated. Next step. So I have to admit that I wrote these unlike Lloyd, who can put everything together in a few minutes and then provide the summation. I wrote these next steps. I cheated. I wrote them yesterday. So you may see things in these next steps that we did discuss, and you may see some things that are new. But these are the sorts of things that we're thinking about in terms of what our next steps are going forward. Obviously, we talked a lot about the consortium today, so it's one of our lead goals for the next quarter or so is to secure 3 to 4 founding members of our Vision Consortium. That will give us the underpinning of being able to actually go forward, with the clinical trials and scaling up the biorepository and so forth. We will, with Jenny's leadership, complete the planning of our first 2 trials that we talked about with the intention of getting them launched in as Jenny said, the second quarter of 2024. As Risa had mentioned, and Julie Rosenthal here, we would very much like to put together an aligned group of pediatric endos and pediatric ophthalmology practices to start to enable the evaluation of some of the same functional endpoints that we're looking at in the adult population, or at least include them in our thinking, in our process, going forward, because it's really important not to forget that cohort of individuals who are more and more going to be affected by retinal disease, sadly, and in particular children, adolescents, young adults with type 2 diabetes. Really think it's important for us to continue to encourage incorporation of our kind of defined basket of promising functional variables in clinical studies of our collaborators. Michael, Chang mentioned this. We're speaking to Ramin Tadioni in his project. We hopefully will be able to align with Aaron Lee and the Bridge to AI program, as well as many of our corporate collaborators, to start to say these are the things that we all should be looking at, and then contribute those to a common database, so that we can learn together on what's going to be the next gen of these metrics of evaluation of function. I think that we've talked about this with George King, and then again with Dr. Chang. We want to, with help, put together our next workshop will be hopefully on principles and methods of omic analysis and best use and centralization, alignment, normalization, harmonization of data and coming out of our ocular tissues, biorepository, and then possibly even create an operating framework for what I've loosely called the Ocular Omics Data Sharing Network. Michael, I'll let you name it, whatever you want. We want to continue to explore the development. I mean, you heard from Dr. Vjosevic, really nothing has met the test, in terms of useful PROs, for diabetic retinal disease. I think the project that's ongoing with FDA, NEI, to think differently about PRO and PRO development and see if there's a common basis for PRO from the functional standpoint that then can be modified for specific indications is of great interest to us. We want to be participating, in that process, because it's very important to us and to all of us to remember to keep the patient voice at top of mind, and patient-reported outcomes are critical. I think I would add to that caregiver-reported outcomes, as well as we talked about today, what I call patient-acquired data. And this is where possibly mobile sensor data and other data that can be collected passively from patients, from all the gadgets and widgets and devices that we all wear, may come into play to give us information. And the group here, mechanical engineering, has some preliminary data on gait, as I talked about earlier, which you can use simple sensors and look at gait and detect early behavioral change in terms of stride length, in terms of pace, and other attributes that could actually give us an early window into individuals who are starting to have important functional visual loss that they don't report otherwise. And then, of course, we're looking towards, as I've said already, but in broader context, working with NEI and Odyssey to look at impacts of data sharing, assessment of impacts, of data sharing, and then finally, as we talked about in this last session, to really start to ramp up, our utilization of the unique assets that we have access to develop messaging and PSA campaigns that, with not just corporate sponsors but the communities sponsoring, to get the messages out that we need to get out to raise awareness. I mean, one of the topics at our external scientific advisory gathering last night was forced recognition of the fact that in many communities there is not even the understanding that diabetes is associated with vision loss. And so if we're operating from that place, there's a lot of work to do at the start to inform and educate populations in need who are disproportionately impacted that, one, if you have diabetes, you should be concerned about your eye health and you should go to get your regular screening. And then beyond that, we can then talk about the more sophisticated messaging that we want to provide, not just to the communities who are affected, but also to clinicians, because we know that going forward, adoption of new technologies and new therapies are also going to be an obstacle to our success. Because ultimately, this is about benefit to the people we love, benefit to patients, and if you don't have awareness on one end, the technology and the therapeutics in the middle, and the people who deliver them to the right patient at the right time in the right circumstances, we're not going to have the effect that we desire. So I just have to say, thank you. I use this. This is a very special picture for me. This is Mary at age 40, dancing with Ben Vereen in a special for television that her company produced. Mary was a dancer, and you all know that. She was particularly, interested in ballet. That is almost a perfect grand jeté, elevating above the ground. A few years after that, she was no longer able to dance because of her vision loss from diabetes. And that's a reminder of what we're really here about. It's about finding the means through which we can preserve and restore joy and independence in people with diabetes and diabetic retinal disease. Thank you all very much.